hearing my voice for the first time, my name is Pharmacist Shatang Dorothy, and I am a critical care pharmacist with the Lagos University Teaching Hospital. And I will be our moderator for this evening's clinical meeting. Before we proceed, I would just like us to kindly ensure the following is done on our devices. Let's ensure that we turn off our mics and only turn them on when we want to ask questions or when we want to make contributions. Also, the chat box is there for those who would like to make comments and wouldn't want to talk. We can always share our thoughts on the comments and the chat box there, and then definitely it will be read and everyone will get to hear our views from that end. This evening, we are going to be discussing a really important topic, especially for us pharmacists. And when we're thinking about clinical pharmacy, we cannot talk about clinical pharmacies without talking about the essential roles that pharmacists play when it comes to medication reconciliation, with the end aim of ensuring that the patient get the best out of their medication. And so this evening, we're going to be having this discussion around medication reconciliation and how it's a tool for minimizing drug therapy problems. Our host for this evening, our presenter rather for this evening, would be announced to us shortly. But then I just want us to have a quick one. Let's get to hear our thoughts on what we think. Let's get interactive a bit. For the next 5 minutes, I'd like us to share our thoughts. What is medication reconciliation? And do we really think, let's even get to hear from ourselves, do we really think that medication reconciliation is essential when it comes to patient care? And if it is, why? Let's start the conversation from that end. So if we have anything to say, let's we can unmute our mic and then we can hear our thoughts on that before we proceed. That way we're able to open our minds as to looking at what to expect from this evening's presentation. So we can just raise our hands, say from the indicates using the chat, just the reactions. If you want to say something about what we are expecting or what our thoughts are on medication reconciliation, we can have that. Okay, we are seeing one hand up. Thank you very much. Let's have you.
Hello. Hello, before they go ahead, please, can you hear me?
Yes, ma'am, loud and clear, ma'am.
Hello? Okay, that's fine. Can you see my screen?
Yes, ma'am, we can see your screen.
Okay, go ahead. Sorry.
Okay. Dr. Anne, you can go ahead, ma'am.
Good evening, everyone. Good evening, presenter and moderator. Good evening, CPAN and all our fellows in the house. I want to comment on your question on if we think that medication reconciliation is important. I would say yes, it's important especially when we're talking about patients that have chronic diseases. For people that are on drugs on a regular basis every day, medication reconciliation is very important. I know in some climates, they actually do medication reconciliation called MTM, and it's a part of the review for any patient that is admitted or discharged from the hospital. But in Nigeria, I think it's more important when it comes to people with chronic issues like diabetes, hypertension, asthma, chronic issues that definitely will require daily medications. Thank you very much.
Thank you very much for your input, Dr. Annie. That was really, really an interesting one. Yes, outside Nigeria, I would say that medication therapy management is usually a part. It's a wide umbrella that encompasses medication reconciliation and the rest. I would just like to hear from maybe one person. Have we had any instance before now when it comes to say we've had to do a medication reconciliation for a patient, and what was the overall outcome after the medication reconciliation was done? What was the overall outcome? We'd just like to hear from us briefly. Okay, Fam Yvonne, your hands is raised. Please, we can hear you. You can speak.
Hello, good evening. My name is Pharmacist Ifechukwude, an intensive care pharmacist. I would like to say here that working in the ICU, we've seen a lot of cases where people come in and maybe the medication reconciliation process was not done for them, or it was later done, and we found out that the medications they were not supposed to be on them due to drug-drug interactions, and it had complicated their situations. Some of them we even lost in the process. So medication reconciliation is very important, it's essential in the hospital, even in community pharmacy, in every area, PISUM, is important to find out the medications the patient was using so that we don't end up with medication therapy, drug therapy problems, like I said earlier. Thank you.
All right, thank you very much for that. So I think with this, we have officially set the tone for this evening's discussion. I'll just briefly have the citation for our presenter. Our presenter for tonight is pharmacist Hadassah Mwese Babalola. She's an alumnus of University of Jos, where she got her Bachelor of Pharmacy degree. She has a Master's of Science in Public Health. Her love for adding value to humanity made her go for a course in critical care pharmacy with the University College Hospital, London. She has since worked in the critical care unit of the Lagos University Teaching Hospital, improving the quality of life of patients. She's a fellow of the West African Postgraduate College of Pharmacists, a merit award winner of the PSN Lagos State, and a distinguished service award winner of AHAPEN. She's a member of Clinical Pharmacists of Nigeria. She is an assistant director of pharmacy at the hospital and currently heads the pharmacy unit of critical care in Lagos University Teaching Hospital. Everyone, please, the floor is now open. Please make welcome pharmacist Hadassah Mwese Babalola. You can just drop your reactions just to encourage her as she comes forward to make her presentation this evening.
Hello, can you hear me? Hello,
yes,
can you hear me?
We can hear you, ma'am.
All right. Yes, I'm so sorry that I'm coming in this late. I have tried to use different devices so as to be. I started around 8:30, and it's unfortunate that with all that I still have to start this late. I want to apologize to everyone for this lateness. I mean, I tried everything to be sure that we started on time, and then that we were able to, not waste time and delve into that which we have to do. But be it as it may, we are here now, and so sorry for keeping my elders some living ancestors I can see here. I can see Professor Val Odili here. So thank you so much for taking our time to be here. I can see Professor Ariola Joda. Thank you so much, Matthew, for taking our time to be here. And I can also see my SIPAN chairman. Good evening, Ma.
Good evening, my dear.
Yeah, so and then I mean, yes, I may not be, yes, I may not be able to call on everyone. The time is fast spent, but I appreciate everyone for taking out time to be here. And without wasting much time, my topic this evening is medication reconciliation, an important tool for minimizing drug therapy problems. One of the things as pharmacists the reason why I actually became a pharmacist is to ensure that people get the best out of the drugs that they take. And the intention of every manufacturer is that they have come to a point where they're looking out for how they can add value to humanity. Now they have gone all through the process, hoping that the drug molecule will give the best to the patient, and then come up issues that that were not the intention of the manufacturers at all. And then these are issues that have become problems for us as pharmacists. You're there, you have looked for your drugs, you have gotten them, you have brought them in, and you're happy that, yes, you're here to treat your patient, you're here to ensure that your patient gets the best. Now, in the midst of all the processes, things then come up that were not imagined, that you never thought, that were not the intention. They were not intended that they should come up. Now, as pharmacists, it has become a clarion call for us to look out for how we can help our patient get the best out of drugs without them having issues. So for this evening, I'm going to talk, we're going to rub minds, we're going to see the clarion call, you know, they've said several things, pharmacists, what do we do and all that. And we're all there trying to put in our best to see how our patients can get the best, our clients can get the best out of drugs. Now, my outline will have an introduction, we'll have the different settings, the outpatient setting, we have medication reconciliation for patients on admission, we have the inpatient setting. We will have 2 case studies, and then we'll talk about medication reconciliation and patient safety. We will talk on medication reconciliation, how it improves health outcomes. The challenges, because of course we need to talk about the challenges. We won't just think that when we have had a very smooth talk here, we will not have challenges. So we have to prepare our minds that, look, these are the things we're going to come up, we're going to meet as we begin to, you know, put our hands to, you know, this process. And so how do we overcome them? You know, how it causes medication reconciliation can shorten the length of stay, the importance of medication reconciliation, especially in critical care settings like the ICU, and strategies for effective medication reconciliation. We'll have our conclusion references, and then we'll have some appendices that we would, I would want us to look at, you know, and see how we can walk around them. Now, by way of introduction, like I started by saying that drugs were intended to do good to our patient. Drug therapy plays a crucial role in the treatment, improvement, and well-being of our patients. However, the benefits of drugs to patients may be compromised due to the occurrence of drug therapy problems. Now, this monster called the drug therapy problem are likely to occur where there are multiple prescriptions. You know, there are comorbidities, there's advanced age, there's advancement in age. Now, just mentioning a few. Now, drug therapy problems, I've just talked about what drug therapy can do. Now, the problems have become a significant public health issue worldwide and has significant increase over the past few decades. It is estimated that around 5 to 10% of hospital admissions are due to drug therapy problems, in which more than half of them are avoidable. Now, worldwide, more than half of medicines are prescribed and dispensed inappropriately. and half of the patients fail to take them correctly. Now, most medications are beneficial with excellent safety profile. Now, the drug therapy problems most times compromise the goal of therapy. You know, for each time you're giving a drug to a patient, there's a goal of therapy. You have what you intend that the drugs should do. Now, the drug therapy problems come along to distort the goal so that we don't get the goal of, just like in a football field, you have the goal, you say, oh, when I play this, I dribble like this and I do this way, and I'm able to put it down the goal post, and then I win. Now we have goals. We don't just give drugs. We have the goals for why we're giving the drugs. Now, drug therapy problems makes this to be compromised, affecting the quality of life of the patient. Now, sometimes it increases hospitalizations, you know, and increases overall health costs, or even leads to death, if not detected and resolved early. So it's very important that that is dictated and it's resolved on time. Now, I'm going to define a number of terms here. You know, there are different, people have come up with different definitions. I wanted us to delve into a few of them, drug therapy problems. And so one of the definitions is that there are unwanted incidents related to medication therapy that actually or potentially affects the desired goal of treatment. That's just, we just said. And then they are categorized into 7. You know, unnecessary drug therapy, there's a need for additional drug therapy, ineffective drug therapy, dosage is too low, dosage is too high, adverse drug reactions, and non-compliance. Now, drug therapy problems can occur at all steps of treatment process. It can be at the prescribing stage, at the transcribing stage, it can be at the dispensing stage, and when the patient is using that medication. Now, and this can occur in both outpatients and inpatients. And this occur at care interfaces. If you would see, I have put that care interfaces in capital. Now, these are vulnerable points for the occurrence of drug therapy problems, those care interfaces. That's where they occur, and if we are not careful, we can miss them and they would get into our practice without us knowing how it happened. So in the course of our discussion now, I'm going to really hammer on those points where we should be vigilant to watch out to see that we do not miss that point, those interfaces where drug therapy problems can occur. Now, we're going to look at that, and then our topic is that medication reconciliation will help us in reducing and minimizing. So at that point of that care interface, the pharmacist is coming in at that point, and it's coming in with this tool of medication reconciliation to help us to reduce and minimize drug therapy problems. Now, medication reconciliation is a structured process that is designed to prevent errors by ensuring consistency in medication regimens. This process is done, if it is done well, it exposes errors due to omissions, duplications, dosing errors or adverse drug reactions, whether actual or potential. It will involve obtaining and verifying the patient's complete medication history, and then comparing it with current orders and resolving any discrepancies. Like I said, this will be done at every point of transition of care. So what is a transition of care? Transition of care is defined by National Transition of Care Coalition. That is transition of care in hospitals. The National Transition of Care Coalition defines transition of care in hospitals as the movement of patients from one practice setting to the other. The transition should be a movement between different healthcare professionals. It can be the movement between healthcare professionals as the clinical situations of patients changes. So it can be from one unit to the other. We're saying that, okay, the patient has entered the theater and maybe is moving from the theater maybe to the recovery room, from the recovery room, maybe the high dependency unit. So as these patients are moving across these points of care, that is where our eyes are looking at. That is transiting from this point to this point. Is everything fine? Is the patient covered well? Are the drugs that the patient is supposed to take, are we saying that what he's supposed to take is what he's supposed to take? The drugs that are supposed to move with this patient, are those the drugs that are moving with this patient? What the drugs are supposed to be removed, are they removed as the patient is moving from this point of care to the next point of care, from one setting to the other? Now, medication reconciliation can be defined, has been defined by the Joint Commission as the process of comparing the medications the patient is taking or should be taken with newly ordered medications in order to resolve discrepancies or potential problems. Also, according to Aronson, medication reconciliation is a systemic process of obtaining the most accurate list of all medication a patient is currently taking. That's taking the best possible medication history, including medications names, the dosages, their frequencies, and the route of administration. Now, this list is to be compared with a list of medications ordered by a physician at admission, or when the patient is being transferred or discharged in order to provide current medications to the patients at all interfaces of care within the hospital. Now, it is a consensus, patient-centered interprofessional process that supports optional medication management. Now, it is also said that it's in medication reconciliation, you do a comprehensive list of medications, and it should include prescription medications, herbal medications, vitamins, nutritional supplements, over-the-counter drugs, vaccines, diagnostic and contrast agents, radioactive medications, parenteral nutrition, blood derivatives, and intravenous solutions. Now, I have come across situations where some clinicians believe that, we should leave out herbal, we should just talk about the orthodox drug, only the prescription drugs and all that. But there's another school of thought that says every single thing that patient is taking should be brought to the table and should be looked at critically to see whether it is it would cause any problem to the patient at any point. Because that's which you want to leave out. You don't know whether that's you're leaving out is actually the problem the patient has had or is going to have if you don't look at it critically. So most patients have unintended medication discrepancies. Now, medication reconciliation is performed by clinical pharmacists. Medication reconciliation performed by clinical pharmacists increases the safety of patients on admission. And then in a study of, I brought in a study to buttress this thing, that where clinical pharmacists are there to conduct medication reconciliation, you will discover that patient safety is upheld in such instances. And then I brought in a study where 151 patients where medication reconciliations was carried on. Then I was discovered that 81 of them at least had one unintentional medication discrepancy on admission. And also another study that shows that a combined intervention efforts of pharmacists and physicians in collaborative medication reconciliation process has a high potential to reduce clinically relevant errors in hospital admission. Now, most medication errors occur as a result of incomplete drug history, communication barriers between healthcare professionals. It can even be between pharmacists. I know that within this week, I've had to really talk about some certain things in my unit where there wasn't a clear, communication between, I'm talking of the same unit now, and it's caused a lot of issues that we have to quickly run to be fast, to run ahead so that we can catch up and even overtake that which that non-communication was going to cause, and communication between carers, in between transition of care, that is very important too. Now, the process of medication, am I still being heard or am I talking to myself? It's so quiet that I'm feeling like no one is hearing. Okay, that's fine.
We wouldn't like to interrupt you now. We are hearing you clear.
Okay, that's fine then. All right, that's fine. Thank you. So now there are basically 5 steps in medication reconciliation. I mean, the traditional, steps that some of us have engaged in, which maybe you develop a list of current medications. That's the first step. The medication that the patient is on, you make a list of them. You keep that aside, that the patient has come into the facility, and then you have gone, you are proactive. You have gone to say, okay, there are models to this thing. So there's a proactive model and retrospective model. Now the proactive model will tell you go ahead and start collecting the medication history, of the patient without waiting for anything, which is our practice in my unit. We would want to go ahead and send either maybe an intern or a technician to go ahead and meet with the patient's relative. In this case, most of the patients that come in are unconscious. So you want to now relate with the person that is there. So it's either they're giving you verbal history of what they know, or you have asked them, what drugs was this patient on? I give you, some of those medications that the patient is on. So you document. So you develop a list of the current medication the patient is on. Then there's a development of the prescription. When the doctors now do their own list too, you develop that list and you bring it in. So you have the current medication list and then the medications of the prescribed medications. Now you compare the medications on the 2 lists, the medications on the current list that the patient is taking and that which the doctors and the physicians have prescribed. Now you make a clinical decision based on the comparison. Then you communicate the new list with the healthcare team and caregivers. Now in my unit, we have an SOP that directs us on how to go. After you have collected it, what next do? You document, you wait for the list of the that the prescribers have done to come in, you compare, then you now tell them what you have seen or what we expect that would happen. And then we now try to see. Now in the critical care unit, of course, because the patient has a list of drugs. As we go into the case study, you will see something that is very, heart-touching. You will see a list of drugs. So how do you ensure that the patients, there are drugs not omitted for the patients, there are no duplications, there are no medication errors and all that? We have this FAST-HOG medicines acronym that we use to be sure that every drug has been covered, there's no omission, and there's no such things that any of those drugs that the patient needs is not omitted or is not duplicated. But as we go on, we're going to look at those things. Let me run quickly so we can get to the point where we can be talking, not only me talking this time, but all of us are talking, bringing in our views on how it should go or should have gone, and all that. So we can all be on the same page of learning. So like I said, medication reconciliation can occur both in outpatient setting and inpatient settings. Now, it's in the outpatient is a systemic process to ensure accurate and complete medication information, and that is communicated across transition of care. This looks a little more simpler. When it is outpatient coming, it looks a lot more simpler, even though there are that you take in order not to miss out on anything. It's also steps that should be taken carefully. But when we get to the inpatient, we'll see that there are more intensive issues you're looking at. This looks straightforward and all that, but then in the being as simple as it is, that shouldn't make us miss out, because sometimes when we look at the whole situation and it's looking as if it's simple, we get so used to it and we'll allow something pass under the bridge that is not supposed to have passed under the bridge. So in the outpatient, now the steps basically that one would take in the outpatient setting is that you take the patient's history and you ask the patient for a list of all the medications. So the medications we're asking the patient out for are the prescription medications. You want to also know some of the over-the-counter drugs that the patient has gotten, whether prescribed or not prescribed, whether he felt, oh, I needed this and the doctor didn't add it for me, so let me go ahead and get it. You know, all those are asked for. Herbal, we can't rule out that. Sometimes after taking for a while, maybe somebody comes in and tells you, oh, this works for me. They brought it for me from one. Somebody in recent times, I've been handling wounds for my mom. And then, you know, there's been a difficulty in healing. And then somebody tells me, oh, this honey, if you get it and all. In fact, I went as far as getting a honey from Cameroon, you know, because everybody will just come and tell you, oh, this one is the best. The one from Cameroon is the best. And because you want the best, we can't rule out this herbal supplements. They will, however you tell them that, look, oh, be careful and all that, they still want to go ahead and get them and together with their drugs, take them. Sometimes if we know, we can even advise how they should, but I mean, we can't rule out that. So we also have to ask whether they're herbal supplements they're taking, whether they're vitamins. We can't rule out vitamins. Oh, I get so stressed up, and so they have asked me to take this vitamin, I'm on it and I'm taking. And then it's also important for us to ask if they have discontinued any medication or there has been any change in their medications too. It's important that that is asked in these settings. Then you verify the medication details. You confirm the name, that's generic or brand, the dose, the route of administration, the frequency of administration, and the last time the patient took the dose, the last dose. You also cross-check against previous hospital records. You have access to that. It will be very important. If you have access to such things, it is very important to take advantage of them so that you can treat your patients. You can manage your patient well. Now, pharmacy refill records, and then also the bottles or list of medications or labels that they may have gotten from their medications. You know, sometimes they would misplace the bottles, but you would find that maybe the label, either they have the label or they have, when they don't have the label on it, you would always advise that however it happens, if a label peels off, please try and not throw it away. You know, so we would be able in the course of reconciliation to be able to help, because sometimes they will come telling you, oh, I think you're a pharmacist, so this color of drug, you should be able to know this color of drug. But most of the time it's better if you have the label or the name of the drug. You know, you can't say from the color of the drug. Well, from years of experience, some people have, but the best thing is that the label, you're able to find the label and to make best use of the label. Then you assess adherence and side effects. Ask about their missed doses. Now, sometimes they miss, not intentionally. They have missed it because they have forgotten. Sometimes they miss it because they are not comfortable with the side effects that come. All this, you should have the rapport in such a way that the patient is able to open up and tell you why he has missed any drug. You know, if there's any change, why have you decided to change? That is also important when you're taking the history. Then identify discrepancies. Look out for duplications. If there are two drugs from the same class, there are omissions, you know, whether they're made, the medications were unintentionally stopped. You know, we need to know if there's incorrect dosing, drug-drug or drug-disease interaction. It is important that you identify out, you get out for all these discrepancies. That will go a long way to help you help the patient better. Now, update the medication list, create a reconciled, accurate, and updated medication list, share it with the patient and other caregivers. Then it is important you educate the patient. If there are changes, explain to the patient why the changes are made. You know, like we know that the patient is a very important factor in what we're doing. We can do everything. You can be in touch, communicate with the doctors, communicate with the nurses, but if the patient is not comfortable with what you're doing, it may just be looking at all of you, all of us, and just be saying, if you will continue, when you finish, then, you know, and it's very important. Like I've always said, having gotten all the drugs and going all around trying to make sure that you get the best quality of drugs and all that, if the molecule does not get into the patient by the end of the day, then we haven't done anything at all. So it is important to educate the patient in such a way that the person is able to, you know, comply and adhere to the drugs that the patient is taking. Now, documentation is very important. It's one thing in my unit that if heads can roll if it is not done, and no matter how tiny you think, oh, this particular thing is not important, put it down. Let it just be on paper and let the paper say it is not important. But not putting it down is a crime. So documentation to ensure that all the records, the reconciled medication list, and any discrepancy or changes in the medical record is, put down. As much as even when they bring infusions to come and change, sometimes they will tell you, okay, no, I just want to change this infusion to another one. Why do you want to change it to that other one? If you have at any point changed any infusion for any nurse, for any patient, document it that the nurse came and said there was, put it down. I would prefer when it is even written on the treatment sheet and brought, and all that. Sometimes they'll tell you, well, I just want to irrigate something and all that, but I'll still tell you, put it down, write it there that you want to use this thing for irrigation or whatever process you want to use it for, mixing reconstitution or whatever it is you're using it for. Every tiny detail is important to be documented. Now, the best practice is to use a structured form or EMR templates. Now, towards the end, at the appendix, there are some structured forms that we have there, and then some different facilities I've come across. Even my own facility now, we're trying to, get all wired up with the EMR. So depending on what is available to you, you make the best use of that. There are standard forms for medication reconciliation. One of them is found in my appendix, and as we go, we will look at it. Now, you perform reconciliation at every visit or after any care transition. You don't say because you did that in the last visit, then it may not be important to repeat it in this visit that a patient has come. Now, there's another very good practice. Now, they call it a brown bag, but it can be any bag. It can be a green bag, depending on what bag the patient has. It can be a white bag. It can be what's the color of bags you put your medications in. You advise them and encourage them to bring them to the hospital each time they come to visit, so you can help look at what they have and what other color of bag they have and have a review with them. That will go a long way, in keeping the patient safe. So medication reconciliation for patients on admissions. There are 3 models. Let me come back to the models. Let me quickly run forward, and then if there's a need, I'll come back to the model. But there are basically 3 models. You have the proactive, the retroactive, or combination of the 2, depending on what model you want to, take up by the end of the day. Now, so like I said, in the inpatient setting, medication reconciliation is more intensive and should occur at 3 key transmission points. That's on admission, during intra-hospital transfer, and at discharge. This is very important. This is why I said in the inpatient, it is more intensive as the patients are moving, because there's a tendency for you to say, because it's within the same hospital, you may not follow the patient. It may not be necessary. Oh, I did it here, so why should I do it when the patient is moving out again? Is it not the same drug the patient is taking? But in order not to miss out on any of these things, you would also still want. Now, right there, while the patient is on admission, even in the intensive care unit, people are sneaking in things. Oh, somebody says, oh, when my patient was on admission in the ICU, this is what I brought and all that, and this helps the patient. And they sneak such things in when they come to visit. So it's important that you empty the drawer of the patient when the patient is moving, even from maybe your ward to another ward, to see that what the patient is moving with is what the patient is supposed to, move with. And then at the point of discharge too, it is important that that is done. Now, on admission, step 1, now the same basic principle of obtaining the best possible medical history. You interview in this case, most of the time when they come into my facility, they are unconscious already. So you're talking to the caregiver or the family as the patient may be unconscious or confused. Now, you use at least 2 sources: patient care interview, or like I said, they have brought the patients have the relative have brought the medications. If they have not brought them, you can advise that they go and bring them, because that will help in the treatment of the patient. And so you encourage them to get them across to you, and all that. Then sometimes some of them would also want to link you up with their community pharmacies, pharmacies, their community pharmacies. You are there and they have said, oh, this is where I get drugs. Can you talk to this patient? Can you talk to this pharmacy? This is where I get my drugs. You can get a better history or information about that which you're asking for, and all that. So sometimes you have to go an extra length to even link up with the community pharmacy to get information about the patient's medications, to get the best possible medication history of the patient, then verify and clarify the drug name, you check the dose, you check the route, the frequency of administration, the indication they're using the drug for, to know when there's unnecessary drug. And then also the last dose that was taken before maybe the patient collapsed or got confused and all that. Then in the next step, you reconcile with admission orders. You have gotten your list. Then the physicians, the doctors have written their own list. You want to compare the list of what they have. Now, for example, we have situations where in my own facility, what we do is that when the patient come with drugs like that, we collect them, especially when they're tablets. We collect them for purposes of even compounding and all that. Since the patient cannot take them like that, you want to pass them through an NG tube and all that. So you collect and you just label them and keep. So if a prescription comes and those drugs that are in that bag one of them is indicated, or as many as are indicated, you take out of that bag and you're able to compound, for the patient. So when the physician's prescription comes in, you want to compare with the medication record you have taken from the caregivers or from the drugs that you have seen to see that nothing is omitted. There's no duplication of drugs as they are writing. There's no dosing error. There's no drug interaction. Then whatever you come across. Now, sometimes when they write this, especially when we have patients that have comorbidities, maybe there's hypertension, there's diabetes and all that, most of this drug, even yesterday, I came across a patient that had a list of drugs, and by the time we put them in an app, we had to be writing down for them because this one just came, he went for clinic and then just came in to say hi. And so I said, let me look at the prescription. And when I looked at the prescription, I will put it through the app. We now saw several, and the only thing we could do was, we couldn't even begin to explain by mouth that this is interacting with this. All we did was that to write down for the patient so that we understand. And then after we did that, I asked him to repeat what we have said to him, to us, so that we can be sure that he understands. Even though we even wrote it on a paper for him, we had to go that extra length so that he can get the best best of the drugs that he's taking. Because most of the times, once it's written, people just take them and say, oh, the doctor has written a prescription. And that's the point where we come in. Yes, they have written a prescription. They don't even have an idea of what that may even occur when the patient begins they've done their job, they've written the prescription and all that. So that's where the pharmacist comes in. Of course, that patient wasn't my patient directly, but I'm a pharmacist, not just in the intensive care unit, but wherever I find myself. So when that came in, I was able to, put it through an app. It brought out the interactions, it brought out several other things that could happen and all that. So I was able to communicate it. And then we also wrote it down because there were a lot of drugs. I don't know how he was going to remember if we didn't write it down on paper for him. So we did that and we hope for the best. And from time to time, since it's someone I know, we'll communicate to know how he's doing on the drugs and what other thing that is coming up that we need to help him out with. Now, during the hospital stay where there's intra-hospital transfer, review medications whenever the patient moves between units, that's maybe from the ICU to the ward, then ensure medication is appropriate for the new care setting that are reordered or stopped. It's important that happens. If the patient is leaving your care setting and you have discovered that a particular issue has been resolved, then it is important to put a stop. Normally the fast hog medicines will tell you that there's a stop date for every drug. So once a patient, a particular issue has been resolved, then it is important to also document that it is resolved and then it's taken off the list. Now, also when the patient is discharged, when we create a final medication list, that will include all medications to be continued at home. Now, you indicate clearly new medication started in the hospital so that the patient would know. Then pre-admission admission medications that are to be continued or stopped. At medications the patient had that he needs to still continue with, or he needs to continue and to stop. Now, if there's any reason for any change, that is also communicated clearly so that the patient would or the caregiver would know the reason for the change or for the continuation of the drug. Then you educate the caregiver, explain the final steps in simple language, just like I was saying about the patient I saw yesterday. Oh, written instructions that's already ensure that they understand the purpose of each drug, when and how to take them, and then potential side effects. Then communicate with the next care provider. If it is going to be intra-hospital, then you communicate with the next setting, the providers in that setting. You know, you would reconcile medication lists. That is done to the patient, that's the caregiver that the patient is going to meet there, you know, and then also the home care providers where it is important. So now the tools that I used here, medication reconciliation form, the EMR. Then in such hospital settings, I would normally advise that patients, pharmacists should lead reconciliation services, you know, especially in places where you have high alert drugs like your insulin or those high alert drugs, anticoagulant opioids. And all that, it's important that the pharmacist should not be found sitting. Pharmacist should not be a sitting doc. The pharmacist should be active up and down. This is where our work starts in earnest. So it is important that you're up and doing so that the patient doesn't miss out on anything. The patient is not taking more than the patient should take. Actually, that is our duty, to ensure that the person gets the best drug, and that the reason why the patient is taking it, the patient, that is being achieved. You know. And so we now come to my first case study, and this is a real case that came from a private ICU to our ICU. So EO was a 60-year-old male, had heart failure secondary to dilated cardiomyopathy, was admitted into our ICU from a private ICU. Now, these are the drugs that were retrieved from the relative because the patient was already unconscious. So we had this list of drugs. We had TAB amiodarone 200 milligrams. It was taken 12 hourly. These were all documented. You have TAB apixaban 2.5 milligrams 12 hourly. There was liquid paraffin 200 mils 12 hourly. Then injection tosamide 10 milligram 8 hourly. TAB voriconazole 200 milligram 12 hourly. These are all the list of the drugs that the patient was on. And so the patient came in and we did this medication reconciliation to come up with a lot of. So when we now put it into an app to help us resolve and sort out the different things that could come out of this, because of course, when you have this kind of a list, just know that you can't just think that, oh, no, nothing, no interaction, nothing, everything is fine, no drug-drug interaction, no drug-disease interaction. In this case, we even found disease drug. You know, the drug febuxostat that was used for the patient for the uric acid, you know, we now discover shouldn't have been used. But this was a drug the patient was using in a private hospital and used it for a very long period of time, you know, until the private hospital could not handle it anymore and they sent to us. So we passed it through. Now, these are all the list of drugs. It's not exaggerated. This is exactly what happened. This list of drugs, I think when I counted them the last time, maybe there were like 22 or thereabout. These are the list of drugs the patient brought in. Now, there is something I still captured here. So the person that got this medication reconciliation done for us, you will see that there's the last drug was written as TAB dozolamide. Now, let me ask, what do we think this drug is meant for? Hello, can somebody just unmute and tell me what dozolamide is used for? Is anyone there? Or have they left me alone to talking to myself?
You are not alone, no. Is it glaucoma? What?
Okay, so now the person doing the medication reconciliation wrote TAB.
Wow, it's an eye drop.
Is an eye drop. So in the I actually left it like that, like
Reduction
this,
of
so that we can see.
intraocular pressure.
Yes, so I actually left it like this so that we see that in the process of reconciliation too, that if we're not careful, we can make a mistake, right? So this person, instead of writing got the Zolamide eye drop, wrote tablet, you know. And so when I was looking at the list, I actually left it like that because that's in the point of reconciliation too. You can have this, you know, where the person taking the drug history makes a mistake, you know, and then records what or document what should not be, you know, and all that. So we should be careful when we're doing the reconciliation. So we went ahead and we looked at this. So when we put it into the app, now the medication reconciliation, definitely we were looking up for whether there were duplications, whether there were drug-drug interaction, or whether there was clinical appropriateness, or whether there's potential omission or optimization needs. Now for therapeutic duplications, we look at the anticoagulants. We could see that there was apixaban and rivaroxaban. Yes, two of them were given together, both oral and all that. I will know what happens in this kind of a case where there's duplication, you know. So it was necessary to do that reconciliation and then advise the caregivers, the physicians appropriately, you know. So we looked up for therapeutic duplications, and of course we found this too. Then if you look at the list again, there was torsemide injection and there was also torsemide tablets. There was an overlap. We don't know, it wasn't clear whether the patient was taking it together. And if the patient was taking it together, why was the patient taking it together? That needed to be clarified. And was it that the patient started with the tablet and then got to the injection, so just had it in the bag? All that was yet to be clarified. And so that is important to be done, so you know exactly why those two drugs were there. And then we had beta blockers. Now we have bisoprolol, and then we have carvedilol. And then the carvedilol we have in 3.125 milligram. We also had a 6.25 milligram. And so it wasn't also clear whether all this were taken together, you know. And then if they were taken together, was that the right thing to have been done? Which would have been best in this patient that was having heart failure, you know, and all that. That also was sorted out for the patient. And then for the laxative, we have liquid paraffin, we have lactulose, we have Dupolax, you know, and all that. And we know what all this does, you know. So it was important to get the one specific that the patient needed, not the three of them. How were they using it, you know, the three at the same time, you know, so that it doesn't result into something more deadlier than what it's supposed to be. And then after the therapeutic duplications, we came into interactions. You know, we noticed that amiodarone and apixaban, that's the anticoagulants, there was interaction between, you know, and there was risk of increased bleeding due to inhibition of at the metabolism end, you know, and all that. So that was also important to, you know, to pass it across and sit down with the doctors and see what should have been done so that the patient can benefit the best from it all. Then we also noticed that voriconazole was also interacting with amiodarone. Then spironolactone, you know, combination of all the drugs were also, there was the spironolactone, then we have empagliflozin, we have metoclozone, we have torsemide. And then, so this ones, there was going to be a high risk of hyperkalemia depending on how the dosing and the timing was. So that was important for us to look at it and also to ensure that there was monitoring of the electrolytes from time to time to ensure that the patient is not getting maybe high on one and then low on the other. Then we also had calcium, iron, and potassium, multiple cations. that would affect GI absorption and worsen constipation. So that's, we looked into that. Then we have midodrine, which is a vasopressor. That would also worsen heart failure in that patient. Then the febuxostat we're talking about, I think at that point, we even advised that allopurinol, which was indicated to be better for this patient, was used instead of, febuxostat. Now, there's a trend I'm noticing. It looks as if this febuxostat is something the doctors are enjoying to write now. So without looking clearly, it shouldn't be taken with patients with cardiac issues, and all that. So, and that most of them come in with all those cardiac issues. And it looks like maybe because they are not aware that this drug is causing issues, they'll prefer this against the traditional allopurinol. But where the information even says that you should go back to using allopurinol and all that. So it's important that we advise them and also inform them that febuxostat, as nice as the name is creating a lot of issues for the patients, especially in people that have cardiac issues. So should be watched and looked at closely. Then those that were unnecessary drugs, like for those that were necessary, like for the levoleucine, Astifa, what were the indications? We needed to know what the indications were, and then to also see whether they can take them off the list and all now. Then we also noticed that the patient had glucose 20.4 grams and said it should be taken when necessary. I'm suspecting that maybe at some point when the patient gets weak in the private hospital, you should just put it in the patient's mouth, just like they say, just be carrying glucose. When you feel weak, you put it in your mouth, and all that. Now, in the intensive care units, we're very careful with this because one of the things you're actually looking at is your glucose management. You're trying to see that the glucose, there's control over the glucose. It can go high at any point in time because of the stress the patient is going through. It can come very low. So you're monitoring very closely. You won't want this kind of loose kind of management or glucose and let the patient be putting it in his mouth anytime he feels tired and all that. You wouldn't want this kind of thing. So as not to, especially in diabetic patients or in ICU at all, you want to be able to monitor what you're doing, not just advise a patient that puts glucose in his mouth when he's feeling weak, and all that. So now the potential omissions of consideration. Valsartan is present. That was good for heart failure and show no duplication with Entresto if used. Now, there were other things that were omitted, like digoxin was not present, and in the patient's management, there were several other omissions that we looked at and we discussed with the healthcare provider, the other caregivers, and that was done. So our action plan now became to discontinue any agent that was being duplicated. And we know that our rivaroxaban and apixaban were duplicated. So it was best to find which was the patient would benefit from more and then choose from that instead of using then the beta blockers. I think we advise on carvedilol to be used for a patient that had with this patient that came with heart failure. Then there was a streamline of laxative and supplement. Then we needed to clarify the route of the tetracycline. Was it IV or was it oral the patient was going to be on? Then in all this, you monitor ECG, electrolytes, renal and liver functions. Then educate the ICU team on reconciliation findings and recommendations. Now, these are the things we felt that should be monitored, and that was also done. Then, in summary, our recommendation was to stop duplication, clarify tosamide routes, rationalize electrolytes and laxative, review the inotrope that was used, then watch out for interactions where there's QT, wave dysfunction, renal function, electrolytes, liver function test, and all that. And then to consider that they stop any medication that is not needed or is not indicated for the patient. So case 2, okay, I think this case 2, we'll take it together so that it doesn't look like I'm the only one talking forever. Hello, are we still there?
Yes, ma, we're here.
It's only one.
Yes, we are here,
Okay. All right, so JP now is a 68 male, came with pneumonia with sepsis, transferred from a nursing home. Now, the past medical history just says it's hypertension, type 2 diabetes, chronic kidney disease, stage 3, and then was on warfarin. So what was going to be the first step of things that were doing? These are the list of drugs that came home from the nursing home with, and with the interview that was had with the doctor. These are the list of drugs. Can we see them? I think we should do this together now. Can we see the list of drugs?
Yeah, we can see them.
Yes, we can see them.
No, not yet. We've seen them now.
Yes, we have seen them. Yes.
Yes. Okay, so that continues and all that. So step 1, was it right the way it was done here?
Yeah, the list of
Okay, so what is the first step? Okay, so when this patient came in, let me ask, what was the first step of thing? What would, as a pharmacist, what was the first thing you would do? Hello?
We need to do assessment of the patient. The first thing to do is to assess the patient.
Okay, so how do you assess the patient, sir?
You will do the vital. You can start with the vital sign, and then you ask for medication history, apart from those ones that have been listed here.
Yeah.
Then
so you want to ask
maybe family history also.
Okay, so we're looking at medication reconciliation now, as in, I mean, straight looking at it, like what's the first thing you want to do when you want to reconcile the patient's medication?
I think we've made the list. Can you hear me?
Yes, I can hear you, sir.
Okay, yeah. I think from the when the patient comes in, so if you can have a brief medical history of the patient, like what he has been suffering from, to then try to compile the list of medications he has been using, so which is what we have, and make sure that we don't anyone. So I think from there, so we look into the various interactions that can come alongside the donations of the medications he has been using, and then we can draw our action plan on it and do our documentation and all.
Yeah, so the first step is get the list of drugs. Since you was coming from a nursing home, you would want to know, have a record of what was taken in from that home, right, and all that. And since the doctor was there to also ask the drugs that the patient was on, it's important to get that done. And then the step 2, on patients, on admission, the patients now, they ordered for meropenem, then warfarin was restarted, but then there was no antihypertensive. Like I said, it's important what we do in my facility so that you don't miss out. There are routine drugs, we call them, it looks like they are routine drugs for the patient. So when the patient comes in, you use the Fast Hug Medicines acronym to be able, what kind of food should this patient be? Should it be enteral? Should it be parenteral? And I'm looking at the fluid too. What type of fluid should the patient be? Should this patient be on normal saline, or should it be on Ringer's lactate? We should be able to say at this point, at every point in time, that look, oh, this is the infusion that this person should be on. Most of the times, we just see infusions, we see normal saline, we see Ringer's lactate, we see 5% dextrose saline, and they're just flying. We don't understand at what point they should be used. You know, it's important to know at that point what kind of infusion the patient should be using so you can advise. Now, for a patient that maybe is high on maybe lactic acid, you know, yes, most of the time that is happening because there's poor tissue perfusion. So you want to quickly maybe use some Ringer's lactate to, you know, quickly move the patient from that stage and then bring the patient to a stage where everything is normal. But because Ringer's lactate has lactate in it, once you have moved the patient out of that, you should be thinking of another infusion that should be used. Should it be normal saline we should use at this point, now that we have moved the patient from, you know, that other extreme of poor tissue perfusion and all that. Now it's a diabetic patient. The patient maybe has gone hypoglycemic. Should you be using 5% dextrose water, or should you challenge the person with 50% at each point in time? So you will be able to advise on what infusion should be used at any. That is very, very important. Then the analgesics, if the patient, you would know when the patient is in pain. The patient can hardly tell you, oh, I'm feeling pain, because they're already unconscious. But, you know, we use this multimodal analgesic management in the ICU. You know, that was the first thing that got me, I mean, how do you use so many analgesics? That was what actually got me into the intensive care unit. You use so many, you're using diclofenac, you're using paracetamol, you're using fentanyl, you're using I couldn't wrap my head around it. So I got involved. I'm like, why are we using all this? And then I understood that, okay, all these are acting at different pathways, right? And because the patient is not communicating to tell you what kind of pain the patient, normally, it still stands that you're asking the patient from a scale of 1 to 10, 10 being the highest. This is how much, if it is up to, I mean, if it is 10 is highest, if it is 1 is low. So between this scale, which at what point do you think you are? And the patient tells you, oh, 7, okay, so you now know that, okay, the patient is feeling this much. Well, the person tells you, it's not much, I think it's 2. But this patient is not talking. So you don't even know where the pain is coming from. So there is this bundle of care they call multimodal pain management, you know, that analgesics are prescribed in low doses, so the patient is benefiting. It's not causing so much harm. Pain benefits, whatever pathway is coming from, whether it is from, you know, there are different pathways, pain pathways, transmission, projection, transduction, and all that. So wherever the pain, what pathway ever the pain is coming from, you know, the drugs are given in such a way that we know that analgesics would either be coming through the pathway of transduction or projection or transmission and all that. So when they're given like that, they go through the pathways to, you know, stop, to inhibit, you know, pain from coming in. So that is important. Then should we sedate the patient? That's the S. There's thromboprophylaxis, definitely, because the patient is not moving. So you know that if this patient is not moving or is even on the big side, you should know that you should do your thromboprophylaxis, you know, and all. And then we have the hyper delirium. That's to, you have to consider whether the person is in any form of delirium, whether it is hyper or whether it's, and then you introduce the drug. Then your also pressure or stress also prophylaxis is important to know. Some that come in with burns, you know, you definitely know that. I think the ulcer is called Collins ulcers. Then those that come in with traumatic brain injury have the Cushing ulcers and all that. So you know that, look, this person is bound. It's definitely going to come down with an ulcer if you don't do anything. So you prophylactically give a PPI, a proton pump inhibitor, to ensure that these ulcers, you know, you cover up so that ulcers do not come in for those patients. And then down the line, you also have your glucose control, the medication reconciliation comes in. So when you have used the fast hug medicine, you're sure that most of those things that should have been omitted, or most of those things that should have been duplicated, you would catch hold of it. As we go on, I'll also show how we've been able to do that in the, in the ICU, So yeah, and then, so what basically we did for this patient is to identify where reconciliation failed. There was a fail in reconciliation. And then also the risk, what risk does omission of warfarin? Because there was a point where warfarin was omitted, and what communication should happen at discharge, and how can this be prevented in future transitions and all that. So looking through the side, I was able to answer, during transfer to ICU, warfarin was unintentionally omitted when switching from IV to oral medications. There was no clear documentation or rationale provided for not restarting warfarin. Nobody said why it was not started, and then at discharge, warfarin remained omitted and no explanation or follow-up plan. Furosemide was added without documentation of indication. And then important home medications like Senna and paracetamol. The Senna, they were using it for constipation, and all that. And it wasn't, they were not reconciled, when the patient came in. Then the risk is that there's increased risk of thromboembolism and stroke. The patient has arterial fibrillation, a high risk of condition for embolic stroke. So sudden discontinuation of anticoagulation without bridging or monitoring can lead to life-threatening complications. And then it can also lead to legal issues, and all that. So it's important that when we're doing this, we should also consider, I've had a case where that almost happened in my institution. A general family, the father, a general, the children all in the army and all that. And somehow the man died and issues came up. Thank God for documentations and to be able to explain at each point what happened. And so that went out on a clean note. But what if those were not done and they wanted a breakdown of the drugs, they wanted what happened and all that, we were not able to, supply all those. So it's important that we're on top of our game so that anything that comes up, and if it takes us to the law, we're able to, explain whatsoever step was taken, and that we will not be found wanting that we were supposed to do a particular thing and we didn't do that thing. So what communication should happen at discharge to the patient and caregiver? Clear explanation that we have already talked of what medications are continued, change, or stop. We have talked about that. Reason for stopping or changing any medication. We've talked about that. Then to the primary caregiver or next facility, you update medication list, clinical rationale for additions or omissions. Then you monitor. Like in this warfarin now, we had to do our INR for, and to ensure that it was safe when we resume or we defer. Now, to any pharmacy that the patient, because I'm saying it's looking like it's far. Most times when they come in, they want to tell you that, look, this is the pharmacy I'm coming from. This is where I buy from. And so much of this information can actually be gotten from those pharmacies, as you create a good rapport with them. And then to prevent future transitions, standardized reconciliations too. We have talked about that and all that. So let me leave this slide out and all that. Now, for medication reconciliation and patient safety, we know that if this is done, will prevent medication errors, discrepancies that could come. If that is carried out, the patient can ensure that the patient's safety it's something we have taken up high. Because most of these medication errors, would be struck off, and all that. There will be reduced adverse drug events. There are apps now. You don't have to begin to cram everything in your head, what drugs should be used, which one should not be used, and all that. You just put them in an app and they separate it out for you clean, and they tell you how to even go about it. And you are able to, communicate to people around you that this is how to go, then medication, it enhances communication. Once you have this information, you wouldn't keep it to yourself. For the best of the patient is to share this information, communicate with other healthcare members in that team that you belong. So for the effective management of the patient. And then that also supports continuity of care, and once continuity of care, it's fine, then you're sure that the patient is safe. And so another one is, what are the health comes? Economic outcomes, you see that there's reduction in health costs when reconciliation is done. You would have seen that some drugs you would have taken of the patient is not on them. If there's duplication, that means the patient should have had more drugs and all that, or would have had some complications that will extend the patient's stay in the hospital. Now, when a patient stays longer in the hospital, of course, we know that the healthcare cost increases and all that. So medications economically helps reduce healthcare costs. Then there's efficiency in care, and all that. Then the clinical outcome will prevent adverse drug events, will improve patient safety. There's better management of disease conditions. Then for the humanistic outcome, most of them, there was a patient that after we had handled in the ICU, after a few weeks, walked back into the ICU and they asked me that, do I know this person? And I said, I've never met this person in my life, of course, because when they're there, all the gadgets that are there, intubations and all that, sometimes they don't look like people you will see and recognize after they have left there. And they said, this is Mr. Sadiq. I said, this cannot be Mr. Sadiq. And he was smiling and said, he is Mr. Sadiq, and all that. And he was happy. Some of them have actually come back to say, oh, I appreciate you people. I didn't know I could come out of this. You see, from the satisfaction that they come back and, they want to come and just say thank you. And, and that makes you happy too. You are satisfied as a practitioner that you have been able to add value. And from what you did, the patient got better and is stepping back to appreciate you. And then it enhances the quality of life of the patient. Then there's patient empowerment. You're able to communicate to the patient how he can handle himself better so that there's no reoccurrence of the complications that would have brought him to the facility, and then there are challenges, like I said. Now, the challenges is when you have polypharmacy and there's frequent change in therapy, and then you have staff, the staff strength is low. Most times it becomes very tiring when you have to go through the same process again, and you're noticing that you're the only person there. You are the only person there to go talk to the patient's relative, form the medication list. Then you are the one going into the ward to meet the doctors again. Then they're coming, they want drugs for some other patients and all that. So sometimes these are the challenges we meet, especially when there's of course, in ICU, definitely polypharmacy is not, I call it that it's a hub for polypharmacy. You would notice that there is no patient that has a list that is just 2 drugs on the list. It cannot be. In fact, after you have even finished with the routine drugs, before you now start talking of what the patient actually brought the patient to the ICU. So you see consults coming from different angles, and when they come, they all want to bring in their drugs for whatsoever treatment. So the pharmacists should be on top of their game to see that, however, whether it is the respiratory people that have come in, whether the O&G people have come in together with what the intensive unit has prescribed, together with maybe the infection control people have prescribed, we're able to streamline these things to ensure that the patient get the best of it. Now, also in the ICU, because the patients cannot communicate. Communication basically is, when the patient is talking to you, can give you better information than when you have to get from somebody around the person. Perhaps maybe the person has not really been around, but he's around because the patient is sick. And then you're not asking questions that the person can't really give you answers to. So that also is a challenge when you're trying to reconcile. Sometimes those omissions are coming because there is no somebody to really talk about and give you the information the way you want it. The person is either unconscious or it cannot communicate with you, so you can't really rely on most. And sometimes when they impute into the system too, they may leave out an information, and all that. All those are challenges when you're reconciling, and this is not restricted only to the ICU. I'm basically just writing it because these are the things we face in the ICU. And then time constraints too is an issue. That one I have already mentioned. It's so fast. It's like a wild wind in ICU. It's like the more you are seeing, the less it looks like you are looking less and you are seeing more, you know, and all that. So it's very important. Big time. Know that time is definitely going to be a constraint. And studies have also shown that other people, me, I am facing it, and anybody that maybe has worked with me will know that time is really, really an issue, you know, and all that. But then what has to be done has to be done. So as much as possible, you put in as much as you can for the benefit of the patient. Then frequent transmissions of care. When you have to move the patient, you know, sometimes they'll just come, we want to move the patient out now. So we need this set of drugs, no, so that we can move the patient out for a procedure and you then come back. And then sometimes you're just saying ×1, ×2, and then you are now trying to say, okay, ×1, how are you going to administer this ×1 or this ×2 that you have written? You know, how are you going to administer to the patient? Why don't you write the way you want to administer so that we can be on the same page? Sometimes there are frictions that come from those kind of issues when you're trying to find out that, okay, no, just don't put ×1 or ×2 or ×5. Yes, we know that you're going to use as much, but can we know how you want to use it on the patient? So most times there's changes, especially when it comes to transition of movement, frequent transmission. It's either they're moving the patient to the theater, they're moving the patient for an outside procedure, they're moving. So all those transitions come along with a lot of issues for the pharmacy. And sometimes it's a challenge for you to be able to reconcile what is happening. And so we also know that when medication reconciliation is done, it reduces hospital stay, prevents adverse drug events, it improves patient treatment efficiency, it reduces readmission, it enhances patient outcome. The importance now being that it is crucial that this is done, like we talked about. Everything I've been talking about this evening is how important it is for medication reconciliation to occur. Then the strategies for effective medication reconciliation with the pharmacist involvement, we should head. When it comes to this, they can say doctors are the head of, whatever healthcare, but when it comes to medication reconciliation, the pharmacist should lead the team in doing this and communicate appropriately to the various disciplines that are involved. That then electronic medical records is a very good tool for reconciliation if it's possible to have it in your institution and do that. But then if it is not possible, then your paper, it's still there to be able to catch as much information as possible, that when you have to talk about the patient, you are not just in tune with what is happening to the patient, but you're well informed to talk about your patient at any time. You know, education and training for other staff. Now, so in conclusion, I want to say that medication reconciliation, we can't do it all alone. We have to involve the nurses, the doctors, because they also need to give us information. I want to state that it's important that we enter the ward. Now, we had an incident where a patient was on ceftriaxone, was also taking calcium gluconate, because I think the patient had a blood transfusion, and when they give the blood transfusion, they will want to give calcium gluconate so that it can accumulate with the citrate that is a preservative in the blood product, you know, and all that. So we now just saw that ceftriaxone was given at that time when calcium gluconate, and the patient started desaturating. And we quickly tried to find out what was happening. And we now notice that when that is done, there's something like a chelation between ceftriaxone and the calcium gluconate, precipitate that will now fall on the lungs and I think the liver and all that. So the patient begins to shut up gradually. I think we lost that patient eventually because we really didn't get what was happening. It was when we sat down to say that, and what could have happened was when this drug was introduced in, that the patient started desaturating. So what would have happened? So we quickly Googled, and then we now noticed that calcium gluconate should not be given together with ceftriaxone, and all that. So, well, we lost that patient, but for the other patients that will come in, we now know that, okay, this shouldn't be given. And we communicated to the other team members so that this is what happened. And so in the next time we'll have is either a period of time is given, they can't be given together at the same time. It should be given times apart and all that. So it is a multidisciplinary process that would involve everybody takes responsibility for the patient. Of course, the doctors take responsibility for performing their roles, and as they're performing their roles, they're able to communicate. The pharmacists take up their roles, and as they're taking up their roles, they're communicating. The nurses also take up their roles, and as they take up their roles, they're communicating. And together is only when we can manage the patients better. Now, these are the references, but then I have something here. There is a medication reconciliation standard. There's a standard document for that. I think I have it. Yeah, this is it. Oh, it didn't come out very clearly. Now, but everybody has to do it to suit them. You can't say that this is a standard. So we were able to craft out something from this medication. We did something that covers everything. So as like a snapshot, you're able to see the fluid. This document you're seeing now is a document that we sat down in our unit and we were able to craft out where we have fluid and fluid. We have the drugs that the patient is going to be on, the medication reconciliation that you do for the patient. Then we also have drug therapy problems if they come with documents. We also have interventions. What intervention? How did you intervene when you came up with this? When this problem came up, drug therapy problem came up. Then a space for also evaluating the lab results and all that, where we can put that down and all that. So we were able to craft something to suit where we're working. So it wouldn't look like the paper, the standard one has become something we're not able to use well, but then we're saying we're trying very hard to use. We just did something that suited us, and that's what we use for our documentation. So we're able to see at a glance if something is missing, and all that. So that's the patient medical bed. So now this is our update here. This is what we do every day for anyone on call. Now, because you may be the only person on call, the other people are off. What we have decided to do is that there are updates every day in the intensive care unit. The person working this night is going to give us an update like this. And the update is going to give a brief of the patient's condition, right? To remind the people that are at home. So she's in the hospital now, but it's going to do this reconciliation where he will tell us about the fluid and fluid, the analgesics, the sedative the patient is using now, the thromboprophylaxis, the drugs that the patient is on. Everything is done like we have seen here, fluid and fluid, analgesics, sedatives, the inotrope, the antibiotics, antifibrinolytics. We have the corticosteroids, better like for this patient now, all this was given to the patient. So at a glance, you're able to know. Now you can see that in this patient, we didn't have sedatives given. The question is, why were sedatives not given? We have to answer the question. Oh, the patient didn't need it. So we would have answered the question that the patient didn't need it. That's why. So, but we highlight, our updates have highlights of all the drugs the patient is taking, and all that. So that the pharmacist that is not on call, that is at home now, once she sees the updates and is coming in tomorrow, he is in on what the patient is on. The drugs that we're giving, they're also handing over, oh, this was not done for the patient. Oh, this particular thing was supposed to be done, maybe a lab test, but it wasn't done. I'm handing over, and all that. All that is done in our updates. If you see down the line, different patients with different drugs. So we have upstairs, we have downstairs. And so all that are listed for the person, for the pharmacist taking over to know exactly what drugs the patients have been on, and then to know how to start from where he's starting up from. There are updates to say, okay, this was supposed to be done for this patient, it wasn't done, or this was supposed to be done, or the relatives said they were going to do this. So we're waiting for that. And as we're waiting, I'm handing over to you. So there is continuity in care. There's no breakdown in the care of the patient from the pharmacist end. you know. So basically, that's what I have for us this evening. And it's not just a good talk, but it's what I think that we as pharmacists can put our hands together to see how we can better the life of our patients. You know, I started by saying that drugs are intended to do our patients good and not bad. So as pharmacists, what basically we're trying to do is that we maintain the intent of why the drug was given to the patient in the first instance. So thank you all for listening. It has been a long time, but I hope I was able to do a thorough job that would cause us, will motivate us to start something if we haven't started. Thank you and have a very good evening.
Thank you very much.
Thank you very much.
Thank you so much.
Thank you.
Yes.
Please,
Thank you very much, Pharmacist Dr. Babalola.
No.
Thank you for the presentation.
Thank you very much.
Thank you for such a long talk.
Can we get a slide?
Of course, I'll send the slides.
Okay, thank you very much, Pharmacist Dasa, for this beautiful presentation. It has been an engaging one so far. If you look at the comment section, we'll see how interactive it has been. A lot of people requesting for
Thank you, Hadassah.
And all. It has been a good one so far. And I think at the start of the presentation, there has been a question, the question of would these slides be available after this presentation? And yes, Pharmacist Babalola just answered. She said it will be made available. And also, this is a fantastic one. So before we just move on, the next session we'll just move on quickly would be the session for questions. And then she get to give us a bit of answers and then contributions. However, I think I'll just quickly want us to reference some of the comments that were made on the comment section. Dr. Uthman said that dozolamide is used to reduce intraocular pressure. Professor Arinola also asked if said something about if you did not document clearly, you'll be unable to prove that you actually did it. And then this is a call to say that as much interventions as we're doing at pharmacies at our various posts, we should ensure that we have these things properly documented. And then she also commented and asked that does the presentation have these useful apps captured? Because I feel like I think all through the presentation we had comments. I mean, the discussion went on to highlight the fact that some apps were used, and so she's asking if these apps were included in the slides. If not, then you might want to share a bit of some of these apps that one could use when it comes to doing the drug-drug interaction. And then several other comments that went on has been, thank you very much for a great presentation and all that. So thank you all so much. Somebody else is raising a question here saying ceftriaxone should not co-administer with calcium gluconate. I think yes, if we do check our Medscape and even you check online, we'll see there's a bit of an interaction between calcium gluconate and ceftriaxone. The idea is that it shouldn't be given together at the same time. Thank you very much, Pharmacist Babalola, for this presentation. So briefly, we've seen how there's been discussion around what drug therapy problem is. We looked at medication reconciliation. We looked at some case studies about one or two, and then she also shared with us strategies through which we can ensure medication reconciliation. And it has been a very interactive one so far. So at this point, we'll be opening the floor for questions, answers, and also comments. So the floor is open for questions, answers, as well as some comments.
Hello, good evening.
How are you?
Yeah, good evening.
Yeah. Thank you so much for the very interactive presentation. Thank you so much for the good job. So my question is regarding this is, having done compiling the list of medications that the patient has been using, and over time, taking into consideration the kind of food, that also we are much into the drug interactions. So there are still some food that some of these patients consumes that may seriously have effect on the therapeutic benefit of their medications. Let's say, for example, for non-ICU this time around. Let's take, for instance, a patient, let's say in inpatient unit, that is ACI, and most of these people coming to visit the sick one in the hospital, they mostly come with one or two food items. Some of them come with something like banana, which is very rich in potassium, and this patient is on ACI. So do we cover the drug interaction alongside the doing medication reconciliation of a patient?
Okay. Okay, sir. Of course, when you're doing medication reconciliation, just has to do with anything, because it will be drug-drug interaction, it will be drug-food interaction. You're also looking at whether there will be drug disease, like in the case of febuxostat, where it shouldn't be used in patients that have cardiac issues, and all that. So in medication reconciliation, it's not just the drugs we're talking about, but you're looking at the reconciliation in these three areas. You're looking at drug, yeah. You're looking at drug food. You're also looking at drug disease, and all that. So it covers those areas too, because if you just do drug and you leave out drug food may be interacting and preventing maybe absorption, preventing or even causing more havoc to the patients than ever. Maybe a particular thing in the food is causing interaction with a drug molecule, and you are not aware. You're just concentrating on drug. So anything that the patient is going to be taking in while the patient is on admission, you're going to be looking, your eyes are going to be all out looking, not just for the drug, but also for the food, and also to look out whether there's also going to be drug disease and issues coming up. Okay. Yeah.
Because I remember when I was with one of my guy like that doing training, so we discover at ARV that some of our patients were not doing fine on their antiretroviral. So he further investigated further. Actually, I was not just learning. So we were able to discover that some of those that were not doing fine were those that attend this Celestial Church, and they take this perfume. So, and I think there's some content in the perfume that has some interaction with some of the ARV drug molecule. So, and with that, their parameters were fine, and we were able to advise them, and they were able to get back on track. So thank you. Okay, yeah.
Thank you, sir. Thank you, sir. Thank you for that contribution. We appreciate it.
Yes, sir.
Okay, we still have another hand up there.
My hand?
Yes, ma'am.
Okay. You can go ahead, Joseph.
Okay, yeah. Thank you so much for the brilliant presentation, ma'am. My question is that what is your relationship or your coordination between pharmacists and physicians, especially in addressing drug related problems? And the next concern is you may measure, even though somebody said it, you may measure some app that you can use immediately to identify these problems between, among patients and things. So I would want you to throw light on that, and also share your experience when it comes to your relationship with physician, because sometimes you identify problems, or drugs-related problems for a patient, and you alone cannot address it because you are not a sole prescriber. So you need to address it with the prescriber. What is the relationship? Is it cordial? Can you share that relationship, or that experience with us so that we can learn from you as well? Thank you.
Okay, sir. So basically, I think in my facility, the relationship is still cordial because based on maybe the setting we have, I think there was a time they were actually coming to call. Once a consultant is going into the ward, he comes in to knock on the pharmacist's door to say he's going. In fact, he was getting upset at some point that he's not coming to call again, that if we do not stand to come and all that. But the challenge also now became when there's only one pharmacist on duty, leaving the pharmacy, if you go on ward round and stand with them, from time to time, they need something that will make you come back to the pharmacy and then you're going back. And because we're handling more than one ICU, we have one down, we have one up. Sometimes you go back to the pharmacy and the people in the down ICU have come to get something. And before you are done with them, they're done with the ward round. But when it comes to the relationship, it's so cordial that, and I'm thinking that is also stemming from the fact that they know that as it is, especially in the intensive care unit, you can't decide that, look, I am the owner of this person. Things are happening so fast that you appreciate, you won't know who would notice what would have slipped past you and would have said, oh, this thing. And then you would have seen that, okay, that thing would have slipped past without you knowing. They've invited us into things like doing the CPR. I think I've been involved in a few CPRs where we all lined up, doctors, pharmacists, nurses, even the technicians. One person gets tired, the other person starts, and all that. So the teamwork has been cordial since we started, and we're not hoping that which is coming up with NMA and us now will not come in between the cordiality that we have between them. Even with the nurses, the pharmacy is such that anyone can walk there at any time, and either to say, oh, I'm so tired, I'm fact that I'm looking for where to sit. This patient has been a case, and all that. And it's more like the whole unit is just together, so working relationship is fine, and we can make it better. There are always ways of making relationships. So for here, where we work, it's cordial. If I'm saying what is not right, I have other pharmacists that work with me here. Maybe they can also come in and talk a bit about that. I don't know, Dorothy, can you talk about the relationship between us and the other team members? Or is Yvonne there? Who wants to talk? Let me also listen.
Let me see if this Yvonne is on the phone. Okay, good evening, everyone. So when it comes to interaction, more or less like the relationship we have with providers, I would say it's a very cordial one, in the sense that the doctors appreciate and actually know the role of the pharmacist. So nobody is trying to encroach into anybody's role or anybody's task. So you will see instances where the doctor is coming into the pharmacy to say, "Fam, please, I'm looking at giving this medication to this patient. What do you think? What are your thoughts on it?" And then the pharmacist is able to say, "Look, this is what I think I want to do. This is what I think should be done. This is what I think is ideal." And then heads are, we share ideas together, and then we're able to come up to say, okay, this is the final and the best decision for a patient. So I'll say that the relationship has absolutely been a fantastic one. There hasn't been really that tussle of, oh, it is my patient, oh, you are just a pharmacist, you don't have to talk to me. But I just feel this all stems from the fact that pharmacists need to also be able to put themselves out there, which I feel is one of the things that we have built over time in the ICU to make people understand that this is what the presence of the pharmacist in the ICU can do for the patient. And then everybody sees, oh, this is actually the pharmacist actually making an impact. So the more people are able to see the impact you're making as a pharmacist, the more appreciated your role will be and the more cordial relationship will be. But it's always important never to overstep boundaries. Maintain the boundaries. You're a pharmacist, do not go beyond your scope. And I think that's one thing that I've guided, I'll say, our relationship in the ICU so far.
Okay.
Okay.
Can
Thank you.
Thank you
And then
for that.
just
Hello?
yeah.
Okay,
Am I-
yes.
Can you hear me?
Yes, I can hear you.
Okay, I have a comment, a contribution to make.
Okay,
For us
sir.
who when we present, we are concerned about the take-home point. What you expect the student or your audience to take home is always a concern in your presentation. And so mine is a comment, not a question, to give us a little more simple information that we can carry home. Reconciliation is a word applicable in many settings, in many specialty areas, ranging from religion to other specialty areas like accountant, social work, even teaching profession as a whole. And so bringing it to our context, education reconciliation. Yes, how does one understand? What does one care as a take-home point is very important. One of the definition that the present gave can be summarized in this fashion. Actually, the systematic steps taken to ensure that medication prescribed are administered based on the appropriate patient, the appropriate illness for the appropriate outcome, which will range in so many dimensions from the steps of assessment and the outcome. If you forget
and command that picture. Relax. I can't say that.
Ensure that the medicament prescribed or that minister are appropriate for the specific cases that are being diagnosed. So when one reconciliation may not be thinking otherwise, but as those who are custodian of medicament, so that the patient has the medicament that is going home with a condition of well-being as our time. So I thank you tonight for this presentation. I'm sure for those who are in clinical practice to be an entrepreneur, have something to take home to so that, like somebody said, your contribution can be recognized and that will be considered as part of the team relevant to patient care. Thank you. God bless you.
Thank you, sir.
I think the comment section is still buzzing with some comments. So someone is asking here, saying, is it possible? Can CPAN do a medication reconciliation chart for distribution to all aspects of pharmacy practice to encourage awareness among practitioners? That's a question there. Better still recommendation. So someone else is asking here, I think Pharmacist Winston, he's saying, where do you do the documentation? Is it in the patient chart or elsewhere?
Are you answering the question? Maybe you should answer. Dorothy, I think you can answer the question.
Okay, so
I shared the chat, right? But you can go ahead and answer the question.
Yes, so it is not the documentation is not done on the so every unit have their charts. The nurses have their charts. Therefore, the pharmacists also have their charts, which is the document that was shared during this presentation. So all of this documentation is done on that patient chart, which is formulated by the pharmacy. So it is totally different from the chart that the nurses would use. The pharmacist creates a chart for the patient at the point of admission. So it is that chart that is being used for the documentation. There's also another comment here. Someone, pharmacist Morrison is saying, is it a good practice during drug reconciliation that a health team, for example, in the ICU, compromise a complication that is not life-threatening during administration of medication?
I don't understand that one.
Okay, the question isn't so clear. If you could further ask that. I think there's also a comment here from pharmacist Jasipo, says that thanks for this professional dialogue. Medication reconciliation requires teamwork involving pharmacists, physicians, nurses, etc. This is a challenge that some physicians working with pharmacists require. So I think that's about that. We have further comments, further contribution.
Sorry, let me say something. If somebody talks about doing a standard reconciliation chart by CPAN, is that what's the question? I think the CPAN chairman is here and would be able to talk in on that question. Ma, please, can you talk into that question, ma?
Okay. Good evening, everyone.
Good evening, ma.
I'm audible.
Yes, you are. We can hear you.
Yes, ma'am.
Hello. The night is fast spent. Time is around after 11.
Wow.
So yeah.
Whoa.
So please, I just want to start by thanking everyone that made it possible to be with us tonight. I saw our dear Dr. Meg Obono. We you. I saw Professor Arilola Joda. I saw Professor Aina, even Professor Ode, who is now the chairman of Faculty of Pharmacy, WAPC, Prof. to have you. I saw up to 4 pharmacists from all the way from Liberia that join us tonight. Dr. Amos, Dr. Patrick, Dr. Morrison, others. We are glad to have you people here with us. Please inform your members over there to always join us every Friday. So I want to appreciate all. This topic, if I want to talk, we'll go to, I'm a critical care pharmacist. So I've written so many questions here, but I don't think I can go on to ask. So please have more questions. You send it to our platform, then she can still answer the questions. Okay, on this note, I just want to end. From what you just asked, yes, CPAN, we have different documentation forms. So we have forms that we use to document patient histories. We have forms we use to document therapy problems. We have forms that we should communicate with other healthcare providers. So we have so many of them. So we have to start to share them again on our national platforms so that we can. I want to appreciate our dear presenter, Dr. Babalola. I'm not surprised.
Pharmacist.
Also, giving closing remarks, need to go. If you have questions, please you can paste them on our national platform and she will attend to your question. So thank you so much for giving us this one lecture tonight. I also want to appreciate the moderator too. She's still our dear colleague in the critical care. So please, I implore pharmacists who want to join us in our own specialty, that's critical care pharmacy. Feel free to contact us. We have our special platform, and also encourage those who have passion to specialize in critical care to start their WAPC and specialize in critical care pharmacy. You will glad you did. So thank you so much tonight.
Thank you, Ma.
Thank you, Ma.
Thank you.
Thank you. Bye-bye. Thank you. Bye-bye.
Moderator, close.
Thank you very much.
All right, have a good night, everyone. Thank you all for joining in.
Thank you.